afternoon, everyone. Thank you so much for taking some time out of your day to be here. I am Jen Prskowski. You guys probably remember me, but I've been on hiatus for a couple of months. I just had a baby. So thanks to the AMDA team and the Drive to Deprescribing team to welcome me back with open arms. Thanks to all of you for welcoming me back with open arms. I am a geriatric and palliative care trained pharmacist, and I am located in Pittsburgh, Pennsylvania. That's where I am today. And I will also be serving as your moderator today. I am filling big shoes since Dr. Press is much better at this than I am, but hopefully I'll do okay. Today is our progress update number 6, where we're going to be sharing strategies, successes, and then secrets. This is really where we want all of you guys to learn from each other. And we have a great guest speaker today that will do just that. Go ahead, Aaron. We'll go to the next slide. Perfect. Just as a reminder for today, participation is encouraged. This is where we want you guys to learn from each other. So please feel free to use the chat function at any time. I will be taking a look at that. All of the Drive to Deprescribe team will be looking at that, and we'll be sending your questions to the appropriate folks as they come. As a reminder, this session is being recorded, as you probably saw when you came into this session, and the slides will soon be available on the Drive to Deprescribe website. Go ahead, Aaron. So today we are revisiting once again antipsychotics. We have heard from all of you the vast number of challenges that can occur when trying to deprescribe antipsychotics. And we've invited Dr. Naqvi here to speak a little bit about her experiences. Before she gets started, I do want to introduce her formally because it is important to do so. She's done so much great work in this field. So Dr. Naqvi is a hospice medical director for the Holy Cross Hospice and Home Care in Maryland. She is a board certified in family medicine, geriatrics, and palliative and hospice medicine. She's also a MOLST master trainer. And for those of you that don't know what the MOLST is, that is the post or POLST or MOST. It is the medical orders for life-sustaining treatments. Her passion is to serve older adults and the staff members at all levels for those who are caring for them. She enjoys learning and teaching. She was appointed Maryland's Medical Director of the Year in 2019. And she also received the Choosing Wisely Campaign Award in 2019 for this work. She's worked super closely with Dr. Nicole Brandt, who is also a colleague of mine, a pharmacist during COVID-19, and developed the medication management deprescribing campaign that some of you probably have seen before. She has led the Advanced Care Planning Task Force and published a 5S Cares Plan Toolkit and Documentation Guide. Excuse me. She is also a member of the Ethics Committee, Education Planning Committee, Policy and Advocacy Policy Committee, and Diversity and Equity and Inclusion Committee. Currently, she serves as the secretary in her local chapter of AMDA. And she is really a transformative leader and also specializes in avoiding burnout. She also enjoys meditation, mindfulness, and yoga for her work-life balance. And really why we invited Dr. Naqvi here today was to tell us a little bit about the successes that she's had in multiple facilities around antipsychotics. We will have her present and then keep your questions ready. And you feel free to put them in the chat. We'll go through them and we'll have an open discussion afterwards. Dr. Naqvi, I pass it off to you.
Thank you. Thank you, Jennifer, and all the power to Rachel, who is listening in with the little baby. I would say all power to you. And all those whose camera are not on. I apologize for all the tongue twisters, Jennifer, you has to use to introduce me. I just like you all, I just a provider caring for older adults. So I do see there is this line on our slide. I'm not sure if, yeah, this one, how it came on. So you will handle the slides for me, Jen?
Aaron is going to be kind enough to move your slides for you, yes.
Okay, so I don't have to worry about taking control or any of that stuff, which I never. I never liked that. So, okay, so I am gonna kind of make it brief and short and sweet for you guys, because I do want to talk about what you're going through and really experiences that you have. You can all hear in well. I'm not too loud, not too low. Okay, great. So, so really, how I want to start is share with you our story of pills, which you all have too, not just me. You know how as we are younger, we are taking maybe just only multivitamins. And then as we grow older, we may develop this and that. And often our patients with develop hypertension, then dyslipidemia, then diabetes, then other chronic illness. And you know how they go to one provider and then the other provider, and then one specialist add one set of medication and the other specialist is adding the other set of medication. And lo and behold, here we are here taking care of older adults, and they have all these bunch of pills of medications. And you know what I say is, if those pills will be more tastier than M&M, maybe I would think of taking them, but I forget to take my multivitamin. Let be known for my older adults how they are keeping up with all the pills. So I think that's really our drive to Deprescribe. We can have the next slide. And I would like to share with you one of the patients whose husband was a physician, and he really made a great impact on how I feel I need to take care of my patients, which you all do also. And that's what he said to me. You know, he was a scientist, and he said to me, you know, I really don't care how much you know until I know how much you care. And I think that's where the key is when we are taking care of our patients. Really, how are we able to communicate in the little time that we have, because we all have crunch of time, which I'm very mindful of. We can go on to the next slide. So let us talk about, you know, where I was and how I was able to help you. So I am going to share my journey with you. And I know you guys, all of you know all the facts, you know all the ways to do it. You are more well-versed than me about all the processes. But I will just share with you how I was, in my small world, was able to make those changes and differences. So I was at a time, it was a time when I was a regional medical director, and I had 6 buildings as a medical director, and 2 of my buildings were under radar of CMS. We can have the next slide. And they were under radar of CMS because their antipsychotic rate was more than 20%. And we can have the next slide. So what really we did, and as you can see, these 2 facilities with the antipsychotic rate. So I am sure you are well aware of the quality measure report. The quality measure report talks about a lot of things, you know, influenza, vaccination status, falls with fracture, falls without fracture, antipsychotic rate, anxiolytics, sedative hypnotics, antidepressant. The newer that was improvement in function, and many other things. But these were 4 of the most salient things we looked into it, and these were 2 of my facilities. And this percentage is not the percentage that is in the CMS reporting. It is the percentages based on the number of patients. So the CMS looks at unreported psychoactive medication use in the absence of any behavior or psychotic symptom, which is a different number from what I am sharing this with you. So it was in 2014. We can go on to the next slide. And then as a medical director, you know, they asked us to kind of look into that. And you all, as a provider, physician, nurse practitioner, pharmacist, whatever your role may be, I would say, you know, always think about why you are doing and what is your drive. So why we need to Deprescribe and what is your drive? For me, it was really when I used to see the patients taking all these medications and my nursing staff who had to give the medication 3 times a day, 4 times a day. They're crushing the pills all the time. They're spending all their time documenting. I mean, you know, I used to feel maybe there is something better they can do to take care of the patients. Maybe they can spend better time with the patients rather than just documenting, giving this and that. So you have to know your drive. And really the key is the quality of life. Imagine all those bunch of medications I showed you. You're taking all this, how would you feel? Each one will have the side effect. We can go to the next slide. So the next slide that I am sharing with you is something I'm going to spend a little bit of more time on this slide. So just bear with me as to what processes we developed and we had, which I'm sure you all are well aware, but I will go into the minute details of how I felt I was able to, with the help of my whole team, make that difference. So as you look through this cycle, as you see, there is no starting or ending point. As you see, it's kind of a circle of life, just goes around and around. But really, it is not, and it's not a daily or a monthly process. It's a constant engagement of you as a provider or whatever your role is with the whole team. So the way we started the process, we kind of always, it was the daily reports the staff used to pick in. And it's not just the role of a medical director or the director of nursing or the case managers. It's really the daily process of what happened in the night. So it is the night shift and the night shift manager, if you have, that's involved with the daily reports, who are able to pick up what is the process, why the patient was restless, rather than jumping to, okay, what antipsychotic was given, you is kind of trying to find what the behavior was, and then making it a real root cause analysis rather than just cutting the, nipping the bud from where it starts off, really looking into the reason of the behavior. And I think for that, it is, and I'm going to mention in another slide down the road with this, how you develop that connection with the team so they feel that they can share what's in their mind. They can share what happened with the patient, and they are not just felt that they just have to kind of shut off and not talk about it. And it's not just a job of 9 to 5 or 7 to 7. And then we used to do our weekly at-risk meetings. There were multiple players involved in the at-risk meeting. Of course, you know, the team leads, but also the recreational therapist, the rehab therapist. And really the pharmacy and therapeutic meeting, which you see in the P&T, is really the involvement of the whole team lead, the case managers, the nurses, the pharmacists, the mental health team members, the GNAs if need be, sometimes the family members, the providers also. And it's really the kind of accountability that we developed. There was a homework that was supposed to be done by the case managers or the nurse of the patient who is being prescribed antipsychotic. And again, the focus is not just antipsychotic, though it is one of the things that we have to look into, but really the key was, what was the behavior? What was the reason? Why did they start it off? Was it dementia present? Was there any other behavior that was eluded before or after the patient was giving medication? And then it was a pharmacy and therapeutic meeting that was done where the whole team lead was there, and the involvement of family, which I'm going to come to it. But again, it's a constant process of engagement with all team members, not just the people who are sitting on the table at the P&T meeting. And it's really ongoing process of connection and reconnection and implementing and seeing what works and what does not work. And now all that process, even if you forget everything I said so far, just remember, talking to the consultants, psychiatrist, to the CNAs, to the family members, to the providers who are giving these medications or helping the patients get better. It's really a process. And the key is the person-centered approach. We can go on to the next slide now. And
Fatima, this is Sabina. May I ask you a question?
Yes.
This is a beautiful concept of that P&T committee and the huge, big engagement conversation you had, did you have any barriers? Were you able to do that right away? I mean, that is something that it stops for most of us right there, that we may be not able to talk to a psychiatrist, or what tips do you have for our audience?
Yes, sure. Of course, there were a lot of barriers. And also in one of the facility, first of all, you have to have a buy-in of what you're trying to do. So you have to have, so I was a medical director. I tell you, I had a chief officer, and I always used to connect with my chief officer, and I had the support of my chief officer. So again, you have to develop a process which is not just another meeting, okay? Because most of the time in long-term care and any place you are, we are always adding meetings and meetings to one after the other. So I think it's really the key concept of what we are trying to do. And that's where I'm gonna, Sabine, come to how we can help our staff understand that this is something that they are involved in this process. It is not that we are putting it down on them. It is how can we help people understand that we are in the trenches with them. So really I think it took a lot of education, of course. It took a lot of understanding. It took a lot of listening. It was more of a servant leader concept. It was very difficult because everybody is very busy. But then I think the things which we did was we kept the time frame that if it is an hour, we will keep it to an hour. And then we would do our homework beforehand for the P&T meeting. And we shared with everybody that it is very important for us to talk about these things, because though we are targeting just antipsychotic, but we found that once the antipsychotic rate was cut down, we realized people know people more. So not just taking care of your patient as a patient or a number. I think it's important to know who this person is that you are taking care of. Like most of the behaviors, I tell you the way they started off. I had a patient it was important. I was a patient, she was a school teacher and she had small kids. So she would get up early at 4 a.m. and she would kind of, that's her day. And so when she had dementia, she went back to her routine and she would just stay up at 4 a.m. and she'd say, I have to go. So everybody thought, oh, this person has this behavior and we need to give them medication to put them to sleep. So when we talked with the son who knew the mom all along, she said, that's what my mom did since I have opened my eyes. So that was one of the things. So really, and then there was a patient who never liked cold coffee. And we kept giving them cold coffee. And then when we talked with the family, we realized that this person always loved hot coffee early in the morning, even before breakfast. So I think it's important for us to understand that we are taking care of people and how we get to know their story, who they are as a person, and then look into the behavior and then look at, okay, what is it that we need to do? And of course, a lot of antipsychotic GDRs may fail, which we did. I had a patient who almost, I wouldn't say that, but who almost kind of traumatized the other one, that we had to call police and all that stuff. But really it's connection, and it's not just connection with the morning team, as I'm saying in here, it's a connection with the night shift staff, how we help them understand that when we go to sleep and we don't worry about all the things, and how they're taking care of the patients, and how we empower the CNAs, and how we share with the recreational team, because they are the ones looking at the behavior. Sometimes housekeeping tell you what bothers. Some of the patients like to go to the bathroom before they go to sleep, or they may go to the bathroom in the middle and they try to get up, and the staff say, oh, this patient was trying to get up, that's why they fell. And when I asked them to go back to bed, they got mad at me. I mean, just simple things have to start first. We can go on to the next slide. I don't want to take too much time, as you know, I can go on forever. But I can tell you this, there are few things, again, with the P&T, I can go forever on pharmacy and therapeutic meeting. And if you'd like to know more about it, I can share what is the pre-P&T homework, what is the pharmacy therapeutic homework. But I can tell you this, and I have no offense to my physician colleagues. it is the pharmacist. Once I came to Maryland 12 years ago, and this pharmacist was an older pharmacist who was almost retiring. So as if I can say he had nothing to lose. And he said to me, Dr. Naqvi, you know, I really want to cut down these medications. And that's where my journey of cutting down of medication started. That's another discussion we can do some other time. But it is very important to involve your pharmacist. And they are the ones who are there to help you. Sometimes we overlook those things. So it's really a team approach, I can say. And then the key is how to motivate the staff. And the staff is not just your staff, the family too. How you create that active layers of connection. And I think what I can tell you this is after COVID pandemic, you know, I used to think, okay, over the phone, it's not as good, of course, as it is in person. But I can tell you, everybody knows when you're talking from your heart, when you are caring for the person you are caring for. How do you build that trust? How do you let CNAs think about and not to worry about that they will be penalized on what they are saying? How can they come to you and tell you, hey, doc, I feel that's wrong with the patient? How do your CNAs are the first ones to pick up the skin breakdown in the sacrum area? Just the same way they know all the patients. And again, it's important in all these meetings or any process that we do, especially with antipsychotic reduction, is to try and close this loop. Whatever system analysis you use, you know, the fish bones, the whys, or hows and how it happened, it is important to close the loop with the team, not just in your own mind. We can go on to the next slide. And I do want to finish on time, so we have questions in the end. So this is a pure picture, I would say a realistic picture of how the staff actually works. Everybody is working hard, you know, the night shift is working hard, the recreational team is working hard. I especially wanted to mention the CNAs because their role is also as equally important as case managers or director of nursing. And really the key is to empower each one of them and have everybody, and think of everybody on the same plane at the same level. And we all are working hard on our own areas, but you see, I don't see much of the harmony on this page as compared to you go on to the next slide, where we all work together and we all try to bring the picture together and complete the picture or close the loop. So we are there for the person who we are caring for. So it's very important. And I think most of the time that's where the success doesn't end up happening as a success, because either we have not made any attempt to have the buy-in of all our stakeholders, or maybe we are not able to help them understand that their, their goals and our goals are the same. I think that's where the journey has to start for us as the leaders of the person who we are caring for. We can go on to the next slide. I do want to mention and take a minute or so in the engagement part, because whatever process you have, I can tell you it's going to be successful. There may be keys here and there which you know now or which you know more than anyone else. But we all face, the speed bumps, you call them, or humps, or whatever you want to call it, dark cloud, or whatever you want to call it. But I tell you, whatever process you start, and you are there for the person or the patient, I call it, and you really want to help them with their quality of life, you will achieve your goal. How do we do that active engagement? Many times we are able to engage the staff, but we may not be able to engage the families. And if we have not done so, then we are not going to be successful. So how do we engage the families? And again, that needs a lot of communication. I know you guys have talked about communication, so I'm not going to dwell on it, but really, I tell you, your patient's family know their loved one more than anybody else, but they trust us that we are taking care of them. But in their mind, as I tell you, they feel their loved one has been how they left their loved one, wherever state of life they were in. That's what's in their mind. And what you get is how they're at this time. So really, it's a journey for the loved ones and the families too, from where their mom or dad is to where they are now, and helping them understand these disease processes and kind of passively explaining to them or educating them, as well as the nursing team and the GNAs, of what this disease process is. And really, I think the important thing is, again, helping them understand, not with your words, but with how you explain it to them, that you really care. And also your presence, your team's presence is there. And worst come worst, if the symptoms come back, you can always put them back on the medications. So it's not an end game. It's not just a dead end. It is just a process we are trying to implement to help our patients. So I really feel that a lot of times the families are very reluctant or resistant, but it's really taking them along with the journey that you are in. We can go on to the next slide. And I really want to share this because I do feel, I think these were two most important things that I have learned over the years, and still I have a lot to learn. But the concept of this mindset change, starting from our end, as well as starting at all levels, really thinking of your team member at the same level is very important. This mindset change has to start from here, from myself. I need to start thinking, but knowing that you are a leader, of course, but it is a servant leader concept, which I don't want to dwell on it. There's a lot that's written on it. And realistic reassurance is something I just created yesterday, because I don't want to give people false hopes. You know, you cannot say, okay, everything will be okay, because your loved one is going through something, but giving them this assurance that we are here and we care, I think is something that everyone is looking for. Next slide. I think I have one or two left. And I do have cases. I would suggest to you, if you have a situation that you feel you're really bogged down and you have a case that you want to discuss, so do put that in the chat. And I hope someone is able to tell me about my time, how much time I have left. So this is a real life case. I had a patient who we were trying to do a GDR. And then we had a mental health team, of a psychiatrist as well as psychotherapist. And in the process, as Sabine, you were asking, what were the hurdles I faced? Really, thank you, Erin. I have 5 minutes. So really what used to happen, it was in the beginning of the process where I think we did not involve the mental health team in our meetings. And I know they are very busy, so we did not involve them with every case, but there were certain cases we felt their presence was needed. So it was one of the patient where as soon as we would do some kind of GDR, the health team would come back and put them back, saying that the patient put them on the previous dose, saying it was a failed GDR. Or there was another thing they did was, they do the GDR, but they initiated a sedative hypnotic. So in this situation, when we talked, first, again, we all have to be on the same page. The healthcare team as well as the providers. And when we talk with them one-to-one, and we have to know how we communicate with who, and it has to be in a respectful manner all the time. So the mental health team member told me that when he talked with the family felt the patient has been on it for so long, and they feared about what would happen. And the second thing was, the member told me, the mental health member told me that the staff kept telling them that this patient has very bad behaviors if you cut them down. So just put them back on because we feel he's going to have a lot of behaviors. So it was just kind of he said, she said, and then we realized, the staff members need more support and education and reassurance. So these were some of the things we were able to handle, along with educating the families as well as the staff. We can go on to the next slide. There was another case that had one of the patient we put the patient on Seroquel at night for frequent behaviors for 2 weeks, as you know, and then we realized that so usually that's a very good question, Kathleen. I'm going to come back to it. So we realized that the patient was given the Seroquel only at night because of the aggressive behaviors. And then we did our root cause analysis to it. And then we went to the family, talked with their staff. We realized that really the key was the patient needed to go to the bathroom more frequently, more than anything else. And so we switched all those things, added a little bit of melatonin, added the routine for the bathroom, and the symptoms improved. The third case that I have, which is the last case, we can go on to the next slide, was the staff would tell you, oh, doc, don't even do an attempt GDR, but the family will get very upset. And I've already shared with you how we need to have the buy-in. And for some patients, you cannot do a GDR, those who are severe schizophrenic. And I can tell you my unsuccessful story was I did do a GDR on a patient who had schizophrenia, who had been on a mental health and a kind of a lockdown unit for 6 months, and we've accepted the patient. And as enthusiastic I was almost a decade ago, I did do a GDR, and we had to call the police because he was standing on another man. So you do get unsuccessful stories, but these are the lessons that we learn and we get better. We can go on to the next slide, and I do have just a few minutes. So what happened to the outcome? What was the outcome of the facility? And again, I tell you, it's not just a day story. It took us 4 years to get to the point where we were trying to do. And every little success that you see, every little thank you that you hear, every few changes that you see is a success to you. And I would say, count those blessings every day you go home while you're driving home. So we did do kind of, it was a successful story. The antipsychotic, for the sake of time, I'm not going to talk to you about all the other successes we did. So this is the percentage of the patients. So one of the facility was a dementia unit. We had only dementia patients with psychosis. We were able to cut down to 41.8. The other facility, we were able to cut down to 8.2. And based on the CMS report, I actually do have the CMS report also, our psychoactive medication who did not, in absence of psychotic related condition, it was a 37.7 rate, which you see, which is a 41.8 in CMS. And at the other facility where the rate is 8.2, the CMS saw it as 4.2 because they did not had any other real psychotic symptoms. So the numbers that you see is not the CMS quality measure report. It is the number of the patient who had it. It took us 4 years. We can go on to the next slide. I do want to be mindful of your questions. So really, what is the take-home message? I think I said too many things in a very short time, and I don't know which one passed over the head and what is stuck to your brain or what is stayed in your heart. Not sure about that. But I would share this with you. Just believe in yourself, whatever processes you take on, keep learning as you're going. Always try and do the root cause analysis of the behavior first before you jump to anything else, let alone the medication or the diagnosis. And always be mindful of your team, because it's the whole team that helps you with the success that you or the whole team as a collectively is making. Sometimes you have a turnover rate that you cannot change, so there's nothing you can do about it. And that's what you work on to stabilize your team and your staff. Second thing is really, it's important to have a mindset of the non-pharmacological strategies. It is very, very important and very prudent to understand. I know a lot of our colleagues have worked on it. Beth has lots of articles on that, and really what non-pharmacological strategies are. I would say just the bottom line is knowing your patient as a person and then starting from there. Always all the 3 E's, really: education to yourself, the active engagement, and really empowering the team so they come to you and tell you, oh, doc, you have to do this. Or my nurse practitioner always tell me what I need to do and I'm learning from them. So really, I think it's really that process of active process that can help, along with including the families. I think this was my last slide. I want to thank you for all your time and open for questions. And I'm going to look into the chat. Jen,
Yeah,
or
Dr.
Michael.
Murphy, there's a question from Linda that I think is really important. She writes, it looks like in some cases you replace the antipsychotic with an anxiolytic. Sorry, I can't talk today. Would you be willing to respond to that, please?
Yes. So again, I would like to share that sometimes that's what happened when our mental health team would be changing the antipsychotic. They would be either adding the antidepressant or adding hypnotherapeutics. And again, I feel, and that's where we had active discussion, and my pharmacist team is here and they can share with us. And really that is not, I would say, not the real root cause analysis. First, we have to know what the behavior is, what you're targeting, and then try to fix that behavior before you want to add on to anything. So sometimes there may be a need of adding a sedative hypnotics or antidepressant or something else, but really you should look out for the trend. It's important to understand if you're cutting down antipsychotic, we monitor the behavior and the behavior changes. I was wondering if we have a question on that. Really the change in the behavior when you cut down any antipsychotic is usually sometimes after 2 weeks, sometimes after 4 weeks. Sometimes you see this change right after a week or so, but it's a time frame that you have to keep an eye on. And that's where you need the engagement of your team. I hope this was, I was able to answer this question.
Thanks, Dr. Murphy. That's really helpful. As we're going through, I'm just seeing if there are other questions. Oh, Dr. Murphy, would you be willing to go back to Kathleen's question? She writes, how long should the observation period be after reduction or discontinuation? Generally speaking, of course.
Yes. So, and again, as I said, usually you see the effect after 2 weeks. And sometimes it's a range, kind of a 2 to 6 weeks. Sometimes you do, because remember, your old patients have what we call homeostenosis. They do not have homeostasis. So homeostasis is kind of a regular function. With older adults, kind of, I don't want to say, but everything gets slowed down. Their processes slow down, their half-life is extended, the medication is staying in their system for longer, it's excreted rate. So whatever you read in the studies is really done mostly on people who are younger than 65. We really don't have multiple areas, true studies on our older adults. So the medication is stay in their system for longer than their real half-life. So what I have seen, the changes that happen is after 2 weeks, most of the time. If it happens between the second day or the same week, then you definitely need to see, is it the staff that are getting restless, or is it there anything else that's happening? And very important thing, is there something going on with the patient? They are going through some acute problem that you are not aware of, and you're blaming it to antipsychotic. People do get infections, they get UTIs, they get pneumonias, and they may not be able to express, and there is a behavior change. So again, it is important to look into those things and make your own checklist if you need to. 2 weeks to 6 weeks is really the time frame for GDR. And again, my next step would be, and I would imagine you asking me, okay, once I've done GDR, I have reduced the medication, I still want to cut down further, what do I do? You know, do I continue GDR? Do I stay at that level, or do I kind of go back on it? What do I do? So that's, again, is the involvement of the families and the team. And for some patients, and we share with the patient that whatever dementia they had, whatever concerns they have, behavior they had, as we all are growing older, our processes are changing, and they may not need the same dose that they needed 10 years ago. So we do, if there is no change in behavior, that usually, and again, it's not in any books, but that's how I did it, was for many patients after 2 months is we would further cut down the medication. And sometimes with some patients who had been on this medication forever, after 3 months, we would attempt a GDR again. And some of the patients stayed on 25 of Seroquel, and they still counted in that number that you saw. But I was happy because I was able to bring the dose down from 125 or 200 to 25. So that's my success story.
We have about 2 minutes left, and there are still a couple of comments and questions I just want to make you aware of. So Carol writes, is there a reference I could review regarding root cause analysis for behavior? This process could change my life as I work with this population who is heavily medicated.
For root cause, I mean, I can share with you some of the books I have read for root cause analysis, but I mean, I tell you, Dr. Google has a lot of answers. If you go into what you do and how you do it, it's really a process. And sometimes I just look at my 3-year-old and how he keeps asking why, and never get fed up from asking why, even before he goes to sleep. I wonder, you know, maybe that's what I need to do rather than consider everything as a norm. So it's really bringing your childlike mind and heart, kind of opening it up and just thinking and asking yourself questions, why you have this behavior, why this is the problem, why we need to give this medication, why we have to stop the medication, why the staff is acting like this, you know, why the night shift keeps giving this, why the family is so restless. Maybe there is a guilt phenomena. So again, I mean, and I can share later down the road all the books, but usually it's kind of the emotional intelligence book, the prime leadership. I can share the names and we can share with you. But if you have any question, feel free to call me. Whatever I can do, I'll help you with.
Thank you, Dr. Nafi. For the sake of time, because it is 5:15, I want to wrap up today's session. Dr. Nafi, thank you so much for your insight and sharing your work with us. Incredibly impressive. And again, I think it really highlights some important take-home messages for all of us. So one, team, think about, does it make more sense in your practice to build Deprescribing into your current processes, or should you create something brand new to say to the team, this is what we're doing new to kind of tackle this problem from a different way? There's really no right or wrong answer, but it sounds like a lot of you like to do a new process, and that's great. Number two, think about the secret sauce. How are you going to engage the residents? How are you going to engage the family? How are you going to engage other providers or prescribers, particularly for antipsychotics? What are you going to do if there is an adverse drug withdrawal event? And then how are you going to think about Deprescribing in regards to if they're going to be a substitution? Are you going to think about another medication, or are you going to go non-pharm straight? So I know that we didn't get to all of your questions, but we want to thank everyone for your time. We look forward to seeing all of you in June, where we will be having our next webinar. And it sounds like antipsychotics is really an important topic, so we will probably stick with that. So we look forward to seeing all of you then. Bye, everybody.
Thank you.